So welcome everyone to this webinar on brain-computer interfaces. My name is Charlie Winkworth-Smith and I lead the Neurotechnology Special Interest Group at the KTN. So I'll just go through a bit of housekeeping before we get going. Due to the large number of people registered, all participants will be muted. But if you've got any technical problems, then please do use the chat box and hopefully my colleague Shelley should be able to help you. If you've got any questions for the speakers, then please use the Q&A box and we'll go through those questions at the end of each presentation. And just to note that the webinar is being recorded. So I'll just run through the agenda. I'm going to give a very quick introduction to the Neurotechnology Special Interest Group. We'll then hear from Damien Coyle, who's going to give an overview of brain-computer interfaces and also a live demo. We'll then hear from Camille Jeunet, who's joining us from France, who's going to be discussing brain-computer interfaces for stroke rehabilitation and athletic performance. And then we have Reinhold Scherer, who's going to be discussing the future of brain-computer interfaces. And then we'll have a quick panel discussion at the end. So as you can see, there's plenty of time for Q&A after each presentation. So please do remember to type your questions into the Q&A box. So for those of you who are new to the KTN's Neurotechnology Special Interest Group, we're here to help. We're here to bring together and grow the neurotechnology community in the UK. So if you've not been in contact with either myself or one of my colleagues at the KTN, then please do get in touch. It'd be great to hear from you to find out what you're working on and see how we can help. Hopefully we can make some useful connections for you. We've also written a couple of reports. So we've looked at the impact of neurotechnology on different disease areas. So we've looked at neuropathic pain, mood and psychotic disorders, and stroke rehabilitation. So the link is at the bottom of the screen, or you can just go onto the KTN website and you'll be able to find those reports. And we've got quite a few more webinars planned. So on the 16th of September, we have neurotechnology for dementia. On the 13th of October, we have neurotechnology capabilities. So you'll hear from the Henry Royce Institute, the Centre for Process Innovation, and the Manufacture of Active Implant and Surgical Instruments facility, the MASI facility. So this would be a great opportunity for you to find out how these centres can help you. So whether it be new materials, how to scale up your wearable manufacturer, or advice on how to manufacture implantables, then do come along and listen to that. And Anne from the MASI facility will also be announcing an exciting call, so do join in. And then on the 12th of November, we have quantum magnetic sensors for brain imaging. If you'd be interested in presenting at that webinar, then please do get in touch with me. My email's at the bottom, or you can use the chat box. Great, so we thought it would be useful for the presenters to understand a bit about the audience today. So we're going to go on to Mentimeter now. Shelley, if you're able to get that going. Brilliant. So if you go onto your mobile phone and type in menti.com, you'll then be able to use the code 59972. And then just a simple question of what type of organization are you from? So industry, academia, medical, government, RTO, investor, or other. So again, go on to menti.com and then use the code 59972. So just as we're waiting for the results to come in, I'd like to introduce our first speaker, Damien Coyle, who is Professor of Neurotechnology at Ulster University and also the founder and CEO of NeuroConcise. So Damien, welcome.
Thank you, Charlie. Just going to share my screen here.
Well, don't share your screen yet. We'll just wait for these results to come in for Menti. I think we've got 100 50 odd people on the call, so hopefully a few more answers will come in. Okay, so we've got quite a good mix. We've got a few from academia, but also industry, government. Okay, I think they're beginning to slow down. So we'll move on to the next question, Shelley, if that's okay. Right, so what is your level of knowledge of brain-computer interfaces? So either are you a specialist in brain-computer interfaces? Are you aware about brain-computer interfaces, but you're not an expert? Or is this completely new to you and you're here to find out for the first time about brain-computer interfaces? Okay, this is very interesting. So Damien and the other speakers, hopefully this will help guide you with your presentations. Okay, great. I think we're slowing down on the numbers there, but that's been very helpful indeed. So Damien, if you'd like to share your screen.
Okay, you should see.
Yeah, that's good.
Yep, all good then. Okay, good morning, everyone. Thank you, Charlie, for the introductions. I'm delighted to be here to talk to everyone this morning. I'm going to cover some basics of brain-computer interfaces, including motor imagery, brain-computer interfaces, and hopefully do a product demo if all works. So I'm based at the Intelligent Systems Research Centre, which is in Northern Ireland on our McGee campus in Derry. It's not too far away from mainland. The Intelligent Systems Research Centre has a grand vision to develop a bio-inspired computational basis for artificial intelligence, and so we've got quite a number of themes, research themes that enable us to do that. Across all those themes, there's a general theme of data analytics and intelligent data analytics. So I'm very much focused on neurotechnology, obviously. We have a lot of nice facilities at the centre as well. Including this recently established spatial computing and neurotechnology innovation hub. So whenever the COVID situation abates, hopefully people will be able to visit and spend some time with us. So I'm going to cover motor imagery, some basics, a little bit around training and how it improves BCI performance, and mainly focus a little bit on BCIs for augmentative and alternative communication devices, in particular for those who have disorders of consciousness following brain injury, and that will be followed by the product demo, FlexEEG product demo. So brain-computer interfaces, just one second on the other pointer, you know, they can be a number of ways to interface with the brain, but we can measure electrical signals in the brain at multiple levels, including, you know, inside the cortex, penetrating the dura, single unit activity, on top of the cortex, electrocardiogram, or non-invasively using EEG, and very much this presentation and I think this webinar is very much focused on non-invasive brain-computer interfaces. But what we like to do in brain-computer interfaces is enable the person to act or communicate with a computer without moving. So they normally perform some intent, such as imagine movement, and that modulates brain activity in the sensory motor cortex. And we try to use advanced algorithms to translate that into an action that can be performed on the computer. So EEG is a non-invasive electrical signal measured from the brain. It's made up of a number of different frequencies, normally in the range 0 to 40 hertz. And if you're not familiar with frequency, 1 hertz is 1 cycle per second, 2 hertz is 2 cycles per second, and so on and so forth. Sorry, it's a little bit slow in reacting here, just 1 second. Oh, not sure why it's going a little bit slow there, but yeah, so this is a not the 40 hertz signal. There are some frequency bands that we can associate with certain mental states. So for example, this mu rhythm here is a not 8 to 12 hertz rhythm that's normally associated with motor cortex or your movement related area of your brain at rest. And then whenever you perform movement, you normally see a change in the activity on the opposite side to the movement, such as the beta signal here, which is 12 to 30 hertz. So normally if the person's imagining right arm movement, you'll see more beta on the opposite side, contralateral to the movement. We know quite a bit about the motor cortex and how it's split up. We know where hand is activated, where feet is activated, where tongue is activated. So it's quite well defined spatially and spectrally. And, you know, as I said earlier, when you imagine right arm movement or perform right arm movement, you get right hand side activity, left hand side activity, left arm movement, right hand side activity, foot movement is center activity, and then tongue movement is down here. So these are 4 mental tasks that we normally use. So imagine movement. The important thing is that imagined movement activates similar areas to physical movement. We normally record signals in a time paradigm where we have a cue at a particular time point, pointing left or right. And at that point, the person begins imagining the movement, and that might involve imagining lifting a weight with the right arm or lifting a weight with the left arm. So normally we classify the signal then as you produce the imagined movement in time. So it's a temporal classification. And what we want to see is in a 2-class scenario, left versus right, that we achieve, you know, greater than 50% accuracy, which is the random accuracy. And so you'll see something like this signal here where we have accuracy presented over time. So at 3 seconds, the person begins the imagined movement. And what we want to see is the accuracy increasing to a peak at a certain point in time. And I just showed this video here. We see that the blue indicates where a left versus right arm movement is maximally separable in the motor cortex or in the brain over time. And at this particular person, they start the movement at 3 seconds. Their peak accuracy occurs around 6.5 seconds. And this is the area that's maximally separable at that point. So there's a number of reasons why we use motor imagery. First of all, it's directly corrected to those motor channels that we normally associate with movement. So if you want to move a cursor on the screen, it makes sense to imagine movement. As I said earlier, movement is imagine movement activates similar areas to movement, so you don't have to be able to move to operate a motor imagery BCI. It's a skill that can be learned as well. So just as you learn to train your motor cortex as a child, in brain-computer interface, you can train your motor cortex to imagine or to control a brain-computer interface. And we know spectrally and spatially where things should be activated when we perform a motor imagery BCI. So this is how the activity looks. And you know, we normally give feedback to the user then to enable them to control the BCI. We normally use quite a number of advanced signal processing. So normally we take signals that are translated through a number of different stages of process. And what we want to see is a signal goes up whenever we imagine left arm movement and down when we imagine right arm movement, as we see here. I'm not going to spend any time on the signal processing side of things. Sorry, this is really slow here for some reason. Yep. Okay, so this is what we have, a control signal here. As I say, it goes up for left arm movement, down for right arm movement, and then we can set thresholds to enable us to do a binary response, yes or no, or 0 or 1. Or we can connect it to a continuous control signal, such as a cursor, and here we have a ball on the screen. So here's an example of brain-computer interface in action, where we're imagining movement to control the character, which is a spacecraft, to dodge these asteroids as they move from left to right, or appear on the left or the right. So in this paradigm, you can actually record data in the top 2 levels, where the ball or the asteroids appear left or right, and the person has to imagine movement to move the character left or right. In the bottom 2 levels, it's a bit more difficult because it's a bit more free play in this scenario. This is speeded up 3 times, but it is actual footage of somebody controlling it and doing quite well in the top 2 levels. There's another example of control in a brain-computer interface where a spinal injured person was imagining movement to adjust the position of the green bars in the bars here, and they have to move the bars above a threshold to perform one of the 6 commands associated with the stopping of this rotating cursor. So this is kind of like a multi-button controller for brain-computer interfaces. Quite challenging because there's a lot going on here. So with these types of feedback scenarios, you want to ensure that a person learns over time to improve their performance. And normally we start off the first time, maybe a person will achieve about 70% accuracy, and then they'll move on and get better over time. So feedback is very important, and I showed you visual feedback. We also have auditory feedback paradigms where it frees up the visual channel. And we've shown through a number of different studies, spinal injury and various other patient groups, that the people can improve their ability to modulate brain activity over time and therefore get better at controlling a brain-computer interface. And this has been reflected in the cybathlon competition, where spinal injured athletes compete against each other, controlling their brain activity to race down a track. And we can see from this training diagram here that they get faster and faster over time with intense focused effort. So there is a lot of things that dictate the performance of a brain-computer interface, and one of those is, you know, deliberate practice, real-time feedback, coaching, you know, mental state and your affective state, and getting into the zone. And I know Camille's going to cover some more about the main challenges with learning and so on. But there's quite a number of patient groups that have been associated with brain-computer interfaces and how they, you know, especially people with physical disabilities who are potentially unable to communicate or interact with technology, and they can potentially benefit from the technology. One such group is people who've had a brain injury and they come through a coma, and they could be diagnosed with what's called a disorders of consciousness. And then there's a spectrum of consciousness following brain injury that's very difficult to diagnose or determine if somebody's aware or conscious because they cannot move to communicate. This is Owen. When I met Owen, he hadn't communicated with anybody for 12 years since he suffered a brain injury as a teenager. He was diagnosed minimally conscious, which is a state where you're assumed to have some level of consciousness, but it's fluctuating and very, very unstable, and very much people are unsure, clinicians are unsure if that awareness is there. So there's a challenge in determining somebody's level of consciousness, and brain-computer interfaces can potentially assist with that, where you put a headset on, you ask the person to imagine movements, and you check if there is clear distinctions between 2 imagined movements. That gives you an indication, excuse me, that the participant or subject has heard you. And potentially then, if they can modulate brain activity, you may be able to enable a communication channel. So we've done this with quite a number of patients who have disorders of consciousness, and we do an initial assessment where we ask the person to imagine squeezing the right hand or wiggling the toes, and we do that multiple times. All they hear is a beep during that, and then we look at the brain response after and determine if there's clear separability between the 2 imagined tasks. If we see that, then we enter them into a second stage of the trial where they get feedback to help them learn to modulate brain activity, and the feedback is in the form of auditory feedback, either musical or pink noise. And then we have a Q&A assessment session where we have a number of different questions that are agreed with the family member or carer. They have a biographical or situational awareness type scenario. And those questions are recorded from the family member and played back to the participant multiple times, and they have to respond by imagining movement. So normally this is what we did in one of our first trials. We started off with 14 patients with either locked-in syndrome, minimally conscious state, or unresponsive wakefulness syndrome. Out of those 14 patients, we've seen 8 in the initial assessment showed signs of awareness because we could see clear differences in their brain response. And then we moved them on into the training with feedback. And then 5 of those also went on to do the Q&A sessions. So these are the demographics of the patients involved. So what we found was that the accuracy in terms of distinguishing between left versus right motor imagery is correlated with the level of severity of the injury or the situation. So UWS performed the worst, MCS a little bit better, LAS, locked-in syndrome a little bit better, and able-bodied then is obviously normally a little bit better as well. So that's what we see here in these trends. And we also show that the time courses of accuracies are also different for each of the different groups, and the spatial distinction between different classes or different motor imageries is also different. So what we have now is a national trial ongoing where we have 17 hospitals involved right across the UK and the Republic of Ireland, and we're quite excited to get going on this. We have already recruited 24 patients, and we hope to get to 40 patients in that trial. So what we do want to do is make sure that we have a technology that's usable and accessible to as many people as possible. So a few years ago, we spun out a company called Neurotechnology Limited, and we've been developing the algorithms, the technology, wearable EEG called FlexEEG. So you can see it here in this diagram. So it's a wearable that's built on a flexible electronic substrate. So it folds around the head, so it's concealable within standard headgear, hats, caps, wigs, and so on. And we've got a cloud connection and obviously some of the other components that go around that. So it's enclosed in that enclosure. As I say, it's embeddable within standard headgear because we want to make it as easy to use and as unobtrusive as possible. It also fits under VR head straps, which is becoming quite popular currently as well. So I'm going to attempt to live demo this technology wearing this EEG cap that I have on me here. So normally I wouldn't do a presentation with a baseball cap on, but I am today, so it's a new one. So if you just give me 1 second, I'll see if I get this up and running. So hopefully it all works now. No, we have a crash. Can everybody see my screen? Yes?
Yes.
So,
yes, yeah.
So, yeah, that's the law of doing present or live demos, isn't it? Crash. So if you just give me 1 second here, I'm gonna. So what I'm going to show you is some EEG live recorded with this headset that I've on. So I've just reset the device there. And I'm going to be using MATLAB to do the demo. And then I will connect to this game here, which is Neurosenses, the name of the game. Okay, apologies for that. So what we have here is some EEG, a little bit noisy on some of the channels, but I've been wearing this now for about an hour or so. basically I'm going to do some teeth grinds, and that'll show you EMG coming in. So that's the teeth grinds, and I'll do some eye blinks. So there's the eye blinks, okay. And I'll close my eyes and you should see some alpha rhythm. So that's a slow 8 to 12 hertz component. So we've all this characteristic noise signals there, and we've a little bit of noise on some of these channels, but I'm not going to mess around with that. So what we've got here is a Simulink model in MATLAB. So we've got our hardware connection, and then we've got some signal processing blocks and some test blocks. So in these blocks, you'll have lots of bandpass filters, and we've got filter bank common spatial patterns. So quite a lot of stuff going on within the blocks. And we've got a UDP receiver here, so we can receive information from another application and we can send information to an application. So what I'm sending here is this control signal, which is fluctuating between 1 and -1. And I'm going to connect to this game. If you just give me a second. Okay. So the game is called Neurotechnology, and Charlie, I know I'm running over a little bit, so if you just give me a second. So it's set inside the brain. Basically, you have a character that is a neuron type character, and the character has to collect spikes as they come up these neurons. So I'm going to try and attempt to collect a few of these spikes now by imagining movement. Yeah. So I'm not going to pretend that I'm going to be accurate at this when I'm talking and trying to, you normally have to get into the zone with this. You have to relax, and it takes a few minutes to do that. And I'm not very relaxed at the minute because I've just had a crash on a live demo with quite a number of people, but thankfully we've got it going here. I just noticed there is 1 or 2 noise issues there on some of those channels, but yeah, they were all perfect earlier. So the setup has 3 bipolar channels here and 5 VEP channels. So we can do motor imagery BCIs and VEP or visual evoked potentials. And I know Reinhold and Camille might touch on those types of control signals. So that's it, folks. The headset is here. Everybody can see that. And this is the electrodes. And it's normally inside an inner cap like this, okay? And here's the flexible technology that folds around the head. So it's got wireless charging, so you just set it on a wireless pad, put it in your cap, connect your electrodes, and away you go. EEG at home in your bedroom, okay? Thank you very much for listening, folks. I hope you enjoyed the presentation.
Thank you very much, Damien. That was fantastic. Just a reminder, everyone, do type your questions into the Q&A box so we can ask Damien. But just as we're waiting for questions to come in, what's been the biggest challenge of taking what was originally some kit in the lab to actually just really compact into a cap? What's been the biggest challenge to get?
Well, the biggest challenge is that with brain-computer interface, you have a large variety of things. You have the signal processing, you have the trials with patients, you have the hardware if you're developing hardware, then you have the end user applications, and it's bringing all that together and trying to get it tried. But in terms of developing the hardware, and this particular hardware, we started out with a flexible substrate on our first prototype. And flexible electronics is very difficult to work with in terms of breakages and solders breaking whenever it bends. So we had to get the grips with that challenge firstly, and yeah, that was a big enough challenge to get it to this point. This is not miniaturized. You could make this a lot smaller, but I think we're quite pleased with the technology to date. Obviously, then electrodes is a big challenge with brain-computer interface. You know, we would like to use this dry. I've got some gel on this cap today, but the electrodes themselves can be used dry. They can touch the scalp. There's got little legs on them. But yeah, you're working with microvolts, and you know the noise issues can be quite a big challenge. So that took us a while to get over as well. Yeah.
Yeah. We've got a question here from Adrian Davis. He says the headset's very good. When will it be in production, and do you know what the cost will be?
Yeah, I was expecting that question. Yeah, so we're hoping to launch the product this year. We're currently getting the packaging ready and various other things. So it will be available within the next 2 to 3 months. COVID situation has slowed us down a little bit. And the price will range between 1,000 and 5,000 depending on what you want to achieve with the device and how many channels and so on. Now that's the price at our current kind of cost of production. Whenever we scale production, we're hoping to drive the price right down, because we think that, you know, everybody should be able to access the technology, and maybe £1,000 is a bit above the price point that some people want to pay.
Yeah. And we've got a question here from Fatima. In which cases within the hospital can this technology be used? So you've mentioned a few studies that you're doing, but what other?
Yeah, so in the hospital, I think, you know, from a disorders of consciousness point of view, when clinical teams, multidisciplinary teams, try to assess patients who have disorders of consciousness, they're normally using you know, very kind of movement related tasks, such as the coma recovery scale revised, or the Essex head index measurement, or the SMART assessment, and these normally involve prolonged assessment of the patient, and, you know, shaking maracas around their head, and gaze following, and various other things, and they're the state of the art in clinical practice currently. So, but they can miss indications of consciousness, especially if the person has no consistent overt motor responses. So I think there is a role for EEG-based technologies in assessing patients who have disorders of consciousness, and we want to make that very easy, where you can basically, you know, go to the patient's bedside, put a headset on, put a set of headphones on, set a tablet beside them, and they go through a set of instructions, and you get a consciousness assessment scale from that. And that can be, it'll not replace existing things, but it can augment clinical practice, I think. And I know Reini and Camille are going to talk about stroke rehabilitation and various other, you know, technologies that can be used in the clinic. But, you know, if we can establish basic yes/no communication channels for some individuals, that would be a huge opportunity. For other individuals who can communicate well, they just want to have alternative means of interaction with technology, and you know, maybe for entertainment and so on. Beyond that, then there's quite a number of other clinical applications in neurofeedback and so on that can be that are being explored as well.
And I suppose a big opportunity for EEG is using it at home. So Raj Sharma here asks, are there any precautions that you need to use when using this at home, or is it, I mean, it's completely safe, presumably?
Yeah, I think it's completely safe. You know, there's, you know, we've got a wireless device, so that, you know, it's battery powered, and it doesn't work when it's connected to the mains. So, or, you know, it's basically, you have to set it on a pad. So it's safe in that sense. Prolonged use over multiple hours, you know, could cause fatigue, and various other things. You know, electrodes, if you're using them dry, they have to be kind of pressurized on the head, which can become discomforting. But beyond that, EEG is fairly risk-free.
We've got a question here from Abel Maciel, sorry if I've not pronounced that correctly, who's researching UX and interaction design. How can people contribute and get involved with what you're doing?
Well, you know, I've shown a basic game there that has an interface, but there's certainly huge opportunities in UX and interface design to create new new ways of kind of using kind of noisy enough, maybe somewhat unstable control signals to do things. You know, I'm showing you here a MATLAB version, but we've got an app called Neuroprecise, and quite a lot of UX has gone into that to show, you know, to basically put all this together into an easy to use app. We've also got an app called Neurotechnology, and that's the clinical app that has you know, consciousness assessment protocols, neurofeedback protocols, and a Q&A system that can record the family member reading out the questions, and then we play them back to the patient. So there's, you know, in terms of the app side of things, there's certainly a lot of opportunities for UX designers. And one thing, you know, that there is this kind of thing in the BCI community that we haven't really had the killer app, you know, yet. So what would be the app that would make everybody get up in the morning, put on a headset, and do something for an hour with EEG? So that's, you know, that's a big challenge for somebody working in gaming or neuro UX or whatever. So yeah, the challenge is out there. Yeah.
And I suppose when you're talking about the Neuroprecise app, maybe this goes some way to answering Stuart Nolan's question, which is what the innovations or benefits of Neuroconcise over other direct consumer products like Muse or Emotive?
Well, I suppose our USP is that we've got a flexible EEG technology that's embeddable in standard headgear, hats, caps, wigs, and so on. It's wireless charging, and it can be used dry or wet. You know, there's new headsets coming online all the time. I think ours has got those that unique selling point that it's on a flexible substrate. Plus, we're growing out of a neurotechnology lab that's in action for the last 17 years. We've got quite a lot of signal processing and AI capability developed within the lab, and you know, we're one of the leading labs in neurotechnology in the UK. So there is a lot of you know, things that have gone on behind the scenes to get this technology to where it is, and we provide a lot of different interface or drivers, APIs. We've got MATLAB, Simulink, C#, C++, Python, you know, quite a number of different drivers that allows our technology to interface with any type of software.
Yeah, thank you. There are lots more questions, but I don't think, unfortunately, we'll have time to answer all of those now, but there is panel discussion at the end. So if we haven't answered your question now, then do bring them back up during the panel discussion. But thank you, Damien, very much. That's been fascinating. And thank you for the live demo as well.
Okay, sorry for the crash, but yeah. Okay.
So I'd like to now introduce Camille Jeunet, who's going to be talking about brain-computer interfaces for stroke rehab and athletic performance. Camille.
Okay. Can you see the slides?
Yeah.
Okay. So good morning, everyone. Thank you very much for being here, and thank you, Damien and Charlie, for the invitation. So during the next 15 minutes, I will present briefly how we can use indeed BCIs to improve motor performance in athletes, and also to restore functions in stroke patients. But I will particularly focus or stress the importance of understanding the mechanisms underlying BCI learning in order to make these technologies usable and actually used outside laboratories. But before we start, please connect or go back to Mentimeter, the Mentimeter website, because I will also use it to ask for your opinion during the talk. So I will provide the code later on. So among the different kinds of BCIs, we will here as well focus on motor imagery-based BCI, so also called MI-BCI, that consists for the users, as Damien explained, to perform motor imagery tasks such as imagining left and right hand movements to make a wheelchair turn left or right respectively, or in imagining foot movements to make a Star Wars spacecraft take off in video game. So I will not explain everything again, but very briefly, why do we use motor imagery to send commands to a BCI? Well, because motor imagery is underlain by modulation of brain activity that can be detected using EEG. For instance, when we imagine left-hand movement, or when we perform a left-hand movement, the amplitude of the EEG signal will theoretically diminish over the right motor cortex. And by analyzing the EEG modulation in real time, then it becomes possible to infer the commands that one aims to send. So MIBCIs are not useful only for control applications, but beyond control applications, they can also be used in the context of neurofeedback training procedures that consist in learning to voluntarily modulate or self-regulate brain rhythms in order to improve or restore associated motor or cognitive abilities. And such neurofeedback training procedures could, for instance, benefit athletes' performance. If you practice sports or music, you know that motor imagery is already much practiced by athletes and musicians. And it has been shown that this motor imagery practice enables athletes, musicians, and others to improve their abilities, for instance, to increase the strength or increase the precision of movements. And thanks to BCIs, we could even improve more the efficiency of motor imagery, because BCIs would enable to provide in real time a neurofeedback, so feedback regarding the modulation of brain activity to the athletes. And this would enable them to target better the rhythms to be modulated when performing motor imagery in order to improve the performance. Then another field for which neurofeedback is promising is the field of stroke rehabilitation. So here, this patient lost the use of his right arm following a stroke. And usually during a rehabilitation process, the therapist would ask the patient to try to move their arm. Here, in the car with a BCI, and the online analysis of the brain activity, it becomes possible to detect when the person or the patient is trying to move, and to provide him with a real-time synchronous feedback on the arm during this motor attempt or motor imagination. Here, the feedback is corresponds to these electrical stimulations that induce a muscle contraction. And this muscle contraction that is synchronized with the movement intent enables somehow to make the brain believe that it managed to move, and this will reinforce what we call the brain plasticity mechanisms and motor recovery. So here in the first few slides, we saw that BCIs were promising both for control applications and for neurofeedback training procedures. But despite these promises, BCIs remain barely used outside laboratories. And this could be due, at least in part, to some reliability issues. It is estimated that around 10 to 30% of the users would be unable to control a BCI. And this, there are several causes that could explain this lack of reliability. First, Damien mentioned them, the fact that the EEG signal that we record has a rather low signal on noise ratio. Second, the fact that the signal processing and machine learning algorithms used to decode the commands are still imperfect and sometimes make errors. And third, another important aspect is the users themselves, because to have a reliable BCI, a double learning is required. Not only the machine has to learn to extract the relevant information from the EEG activity, but also the user has to learn to produce clear and stable EEG patterns that can be recognized by the system. And currently, I will not enter into the details, but this is the kind of training procedure that we use. And these training procedures, and especially the feedback that we provide, that is this blue bar that you will see in a second, that informs about the performance, are quite basic and may not actually help users to learn to control a BCI. So obviously, one main challenge is to design innovative, adapted, and efficient training procedures that would enable each user to learn to control a BCI. But to do so, a necessary first step would consist in understanding the cognitive, psychological, and neurophysiological processes that underlie user learning in BCI, so that then we can design relevant training procedures. So in the next few slides, I will briefly introduce some of the work that we've been doing on the topic. And first, based on the literature and on experiments that we led, we tried to model the factors that influence BCI performance and learning. And so here, neither I will not enter into the details because we have no time, but we can go back to that during the question if you're interested. So we have identified 3 categories of factors that could have an influence. First, factors related to spatial abilities that correspond to the ability to produce and manipulate mental images. Then factors related to cognition and motivation that include attentional abilities, for instance, and then factors related to technology acceptance that relate to the extent to which participants feel confident and secure when interacting with the BCI. So now the validity of the theoretical model would need absolutely to be formally tested. The problem that we have is that if we want to test it, it would require to lead a lot of experiments with a lot of participants and a lot of sessions per participants. And given the way research works, this is not doable by a single lab. And this is why we came up with an initiative that we call the Big Shared MI-BCI protocol, to which more than 20 labs agreed to take part, including Reinhold and Damien here. And the idea is to collectively design a sound protocol based on the literature, and then to include a few participants in each lab, and finally to share the data in order to investigate learning processes on a large cohort. So if among you some want to join, please do not hesitate to contact me. And at the moment, of course, we are looking for funding for this project. So we have this model. It's not perfect yet, of course, but still it enabled us to highlight some influential factors and to already design some innovative feedback. So I will introduce 2 examples of such feedbacks that are, of course, preliminary. So first, we have shown that visual feedback, so this blue bar that you saw earlier, was not intuitive and require too many cognitive resources to be processed. And it seems to us that a feedback on the hands would be more intuitive when it comes to controlling a BCI through left and right hand motor imagery. So we designed vibrotactile gloves that you see here that would provide feedback on the hands to inform participants if left or right hand motor imagery was recognized by the system. And we compared this tactile feedback, vibrotactile feedback, to a standard visual feedback, a cursor on screen. And at the same time, people were imagining left and right hand movement to control their spacecraft and protect their planet. They had to count distractors, so either the rockets that were sent by the tank or clouds in the sky that you should see in a second, yes, or rabbits on the floor. And our results show that the participants who were provided with the tactile feedback had better performances both at the motor imagery task and at counting distractors, which suggests that tactile feedback would be more relevant and would require less cognitive resources to be processed. Of course, there are many hypotheses, so here again we can discuss them if you want. So this was about the form of the feedback, but we also worked on the content of the feedback because currently only a cognitive feedback informing about performance is usually provided during BCI training. And the thing is that we know that emotional support is also very important. And what is more, because it has been shown that anxious and non-autonomous users had difficulties learning to use a BCI. And this is why we designed a learning companion that is called Peanut, and that provides emotional support to the participants depending on their performance and progression. So now please go to Mentimeter and type the code 499441 and answer the question. So what do you think of this little Peanut? Do you think you would like, honestly, if you would like to be accompanied by Peanut during a BCI training, or do you think that this would be super annoying for you? So I let few seconds to reply. Okay. Okay, so these are very typical results. We have about 2/3 of people who would like to be accompanied by Peanut, and another third who would think that it would be super annoying for them. And this is very interesting, and this stresses the importance of modeling the user profile to know how to adapt the training procedure to each user. So in this first part, we've seen that improving the reliability of BCIs through machine learning, improvement of the sensors, and improvement of the training procedures is the main challenge for the community at the moment. But I would like to stress the fact that there is another challenge that should not be neglected. This challenge is to improve the BCI acceptability, because even if BCIs get reliable, they will not be used in practice if they are not accepted by users and patients. And BCI, the acceptability of BCIs can be impaired by many different factors. First, we've been talking about that in the previous presentation by Damien, the brain recording, the brain activity recording method. So here, we have the choice, let's say, between EEG, for which the signals are somehow not that good, somehow noisy, and that can be stigmatizing. And this is why Damien's work is very important, because having an EEG cap under cap is really less stigmatizing than when you can see this on the head of a patient. So you have this method, and on the other side you also have some invasive methods that can provide a signal of better quality, but at the risk of a surgical operation. Then there is the issue of perceived usefulness. So we were talking about stroke earlier. So there are two recent meta-analyses that suggest that indeed, BCIs enable a better motor recovery than standard rehabilitation methods. But still, the level of evidence is quite low. And in other fields for which BCIs or neurofeedback are used, it's even lower. So it's complicated, and we have to really think about a way to motivate and engage users and patients in the training, while it's a long, difficult training with a low level of evidence for the results. Then there is a third issue, we talked about that just earlier, is the accessibility issue, because EEG equipment and BCIs in general are quite expensive, and so not everybody can offer them, and also it requires some expertise to put the cap on, etc. So we would need to think of politics to make this technology accessible. And finally, of course, there is another issue, which is the reliability and security issues. Like for autonomous cars, you have to be able to, when there is an accident, to figure out where does the accident come from. And in BCIs, it's difficult to disentangle reason related to hardware, software, or to the user. So this is one of my main research topics at the moment, and we are here again trying to design a model that should help us better understand the intrinsic and extrinsic factors that influence BCI acceptability and acceptance in terms of perceived usefulness, perceived ease of use, and behavioral intention. And thereby, this model should provide insights on how to adapt BCI systems and trainings to optimize their acceptability and acceptance. And here I would like to go back to a question that Abel asked earlier, and I think we really need people from the fields of ergonomics, UX design, and so on to design such protocols. So to conclude, I would like to recapitulate a bit some key take-home messages. So first, understanding the learning processes underlying BCI use and improving the training protocols accordingly is really essential for BCIs to be reliable enough for everyday application. Then neurofeedback training procedures are very promising to improve or restore motor performance in conditions that they are acceptable and usable. And the third one is that we should really not neglect the importance of acceptability and acceptance of these technologies, because the more the technology is accepted, the better people are engaged into the training, and then this could have a positive influence also on the reliability of BCIs. Okay, so I will stop there, and I would like to finish on this slide in which some of my colleagues are featured, and I would like to thank them because nothing would be possible without their help. So thank you very much.
Thank you, Camille. That was really, really interesting. We've already got some questions coming in. So Samit Chakrabarti asks, when you say real time, what is the delay time you're referring to?
Okay, so using EEG, it's only a few milliseconds between the the neurophysiological process and the time that we can record it. Then for the feedback that we provide, usually the feedback, this blue bar that you saw, is computed, at least we computed over a 1 second signal of signal. And then we have sliding windows advancing in time. So the delay is quite low.
Yeah. We've got another question here from Stuart Nolan about Peanut. He's asking, have you looked at other characters as the helper? He wonders if some negative responses may be to Peanut specifically, rather than having a helper in general. But he says he likes Peanut.
This is, yeah, thank you for Peanut. He will be happy to know. Yeah, this is good question. So basically Peanut, we had participatory design approach to design it. So we made many studies regarding its appearance, the kind of interventions that it provided, so that we ensure at first that it would be designed as well as possible, but then we didn't compare it to other companions. But we know that for some people would prefer human presence, others this kind of learning companion, physical learning companions, and others more virtual things. So there is really a lot of work to do on the topic, and this is where we need more people from UX, ergonomics, and cognitive sciences to investigate this kind of different social support.
Yeah. There are a couple of questions about Peanut, so I'd encourage those people to get in touch with you, because I think there's really interesting work to do there. Paul Bannequed, I hope I pronounced that right, asks, is there a particular protocol or strategy to hand motor imagery, i.e. do we imagine a slow grasping movement or a fast repetitive closing of the hand? How?
Yeah. Okay, so this is again very good question. So there are different ways of practicing motor imagery. First, there are two big categories that are visual motor imagery and kinesthetic motor imagery. So visual motor imagery would be more like visualizing a hand moving in first or third person perspective, while kinesthetic, which is requires more the motor cortex, and this is what we ask participants to do, is really to feel like we were sending a motor command and feel the movement that we would perform. So this is about the types of motor imagery. Then there are different frequency, amplitude of movements at which we can perform them. And this is still an open question. So that if you're interested in this question, there's been a thesis in France by Sébastien Rimbert, who investigated a little bit the difference of recognition in the EEG depending on continuous movement or discrete movement or cyclic movements. And there are differences in the amplitude of the synchronization and desynchronization of the EEG depending on the frequency of the movements, trends, etc. But it's still a very open question. And here again, we don't have for now the best strategy that has been uncovered so that it's recognized as well as possible. So I would say that for now we use trials and errors with the participants to figure out which one is the best for them, and we adapt the classifiers to each of them.
Yeah. Have you had much interaction with the games industry? Because a lot of what you're doing is based on quite simple games. I imagine if they were more complex, perhaps, just even visually, there'd be more engagement, so that training would be more enjoyable.
Yeah, so I have not, but there are some teams working a bit more with virtual reality companies and so on. And indeed, to be honest, I think that the human training part has been a bit neglected in the past years. So we kept this very simple interface, thinking that if we improve the machine learning, it will be sufficient to have good performances. And now people are getting back more and more to the topic, and Reinhold Scherer, who will talk just after, he's a leader on the topic. So, and I would say that indeed gamification is a really good way to improve engagement. Then we have to be careful, because we should not overload cognitively the participants. So it's always a bit tricky to find the correct trade-off between gamification and cognitive load. And it's also an open question when to go to the next level and make the whole game process progress so that people optimize their learning or skill acquisition. And these are also questions that we ask in the big protocol project with Heini and Damien.
Yeah, well, I think that's perhaps a good time now to bring in Reini. So Camille, thank you very much. That was fascinating. So I'd like to introduce now Reinhold Scherer, who's going to be talking about the future of brain-computer interfaces. I think you're on mute at the moment.
Yeah, so perfect. Let me just try to share the screen. Always the same issues, no? We develop BCIs, but screen sharing, it's a big issue. So wait, let me go share. Okay. No, can you see my?
Yeah, perfect.
Excellent. Wait, I just now lost. No, wait. Something went wrong. Share again, share. Screen number 2, share. Okay.
Yeah, that's good.
Excellent. So again, so sorry for this. Thank you for the invitation, first of all, for having me here and giving me the opportunity to show some of the things I did in the past, or we are doing now at the University of Essex, which is basically, I just moved here last year, so I'm fairly new. So this is also a good opportunity for me to connect with people and just to enhance my network, let's say it this way. What I would like to do now in the next 15 to 20 minutes is I give you an overview about some of the basics. You already learned many of those, but I would like to recap them so that we are sure that we all are on the same page. And then I would like to give you show you different ways how BCI can be used for, or what are they good for, based on a European project, which now 5 years ago, came up with a roadmap for neurotechnology and BCI. And then, of course, I will give you outline some current developments. This is just a selection. So I've seen there are many academics here, so apologies if I do not manage, or if I forget to mention your developments. There are just so many. I try to have a cohesive little story, hopefully. And then, of course, we will translate this into some future directions, or we can try to infer some of the future directions, because this making prediction of what's going on in the future is very, very challenging, I guess. I guess we all can agree on this. But let's start with the basics. So let's start with the electroencephalogram, the EEG. We heard it already several times. But what I would like to start with is with the source of the signal. Yeah. So what you see here on the left-hand side, no, sorry, I just have to the laser pointer. Here on the left-hand side, you see an image of the brain. It's basically a section through the brain. You see the outer layer, which is more grayish, which is the gray matter. You see the inner layer, which is white. And the outer layer is basically the cortex, where the neurons, the signal processing cells, are embedded. So in the outer layer, you see this here on the right-hand side of this image, the scheme of different neurons. They sit there and they do the processing, if we compare it to computer. And the white matter inside the brain here, this is more or less the cabling, if we keep this analogy. Now, information processing and transmission inside the brain or inside neurons, which are these cells, works with bioelectrochemical processes. But for our purpose today is enough if we know it's bioelectricity. So basically there are electric currents flowing. And the red arrows, which you see here, this symbolize the currents. Now, if a currents flow, I hope this is visible. You see here this yellowy line. This is the so-called volume conduction. It's basically like if you throw a stone into a lake, for example, into a river, you see the waves propagate. It's the very same principle we use here. There are currents flowing, the waves generated, they propagate, and we can measure them on the outside by use of sensors, like in this case. And of course, for the electrical engineers among you, if there's a current, there's also a magnetic field. So the B here in this image is the magnetic field. And now you can also imagine that the brain, which consists of billions of neurons. So if we want to measure the activity on the outside from individual neurons, this is quite a challenging task. But what we can do is we can measure the activity of millions of neurons if they synchronize somehow this activity. And if they synchronize this activity, then what happens is we measured, or then they generate these oscillations, this rhythm, which already Damien was talking about. And what you see here on this diagram, you see here on the x-axis, this is the time. Each of these squiggly lines is a different trial. So at this time point here, users started motor imagery. We already heard what motor imagery is, so the imagination of movement, whatever. So which movement, what precise movement instruction, we also learned is quite challenging to instruct people, or if people have never moved, like we did with user who has cerebral palsy. So it's quite challenging. But it's well established because we know from topology and from the dynamics where to get the signal. So if you look at the upper part here, you see many of these dots, which are the different electrodes, which we already seen in Damien's talk, and to record signals, EEG signals from all of these different sources. And what we find now in this case, if a user at this time point here, again, this is 1 second, just again to give you an idea about the dynamics, starts performing motor imagery, then what we find in this very specific individual is that, again, we talk about oscillation. So oscillation in the 15 to 18 hertz range. What we suddenly see is an increase in amplitude. I guess this is very visually easy to see, hopefully. But what you also see is that even if we instruct or ask users at time point 0 here to do or perform motor imagery, what's happening, you see there's a delay here, 2.5 seconds, 3 seconds. It starts more or less right away. The amplitude is not so high. So it's a really large jitter, let's say. Yeah, but this is the reality we have to face with. But since we can visually see this, it's also straightforward to, it's not really straightforward, but what we can do is we can also train a machine to identify or detect this pattern. And this is how we establish or how we develop a brain-computer interface. So basically we acquire the signal, we extract multivariate data, so many signals from this data, but at the end what we need to do, we need to extract some characteristic features, so which really contain information about what we want to do. Like in this case here, we can have 64 channels here, for example. We break it down to the 2 most important channels so that we then can use a pattern recognition method, which discriminates, like in this case here, the axis versus the circles, and X now could be a motor imagery task, and circle could be a non-motor imagery task. And then we can translate this X or this 0 into a command, which basically simulates a button press. So each time I imagine motor imagery, I press my button with this brain, otherwise I don't press it. Then of course, this signal is then sent to end-use application, which can be of various kind. And we will go now through different types of applications. Oh, before I forget this, but this was already mentioned, BCI is really a closed loop system. So the human generates signals, the machine has to detect those, but then of course, via proprioception, via sensory feedback, we adapt what we need to do. And so we close this feedback loop. So it's a closed loop feedback. That's very important. But let's go to the application before I run out of time. We already heard about some of them. The first one, if we stick to the future BNCI roadmap, is the restore of lost function. Imagine we have patients who have, for example, a spinal cord injury, which cannot control their muscle because of obvious reason, because the connection to the muscle is damaged. But we could create a bypass, for example, or to the bladder function, so that people can be, again, to some extent at least, autonomous. What I would like to show you here in this video, this is basically the first patients I had the pleasure to work with when I started my PhD. This is a spinal cord injured patient, and you see he cannot grasp. He has some residual functionality in the elbow and in the shoulder, but he cannot use his hand. And what we did at that time, you see this fancy cap, it still looks not as sophisticated as Damien's system, but you see by bypassing the interruption in the spinal cord and by stimulating the muscles, so we decode the activity from the brain, motor imagery, I would like to move my hand, we detect this and we then stimulate the muscle. Of course, we cannot do or not yet, we should say, do a perfect 3D reconstruction of what's going on in the brain in terms of motor. So we go back to this very simple binary switch we discussed before. So if we talk about functional electrical stimulation and you put stimulation electrode over specific parts of the muscles, and assuming the muscle is still innervated so that the electrical pulses also reach the motor points, then by stimulating, we can make the muscle contract. And in this case, what happened in this experiment, which you have just seen, we had this 3 channel, 1, 2, 3. If we stimulate the first channel, then the hand would open. Then the user can grasp the glass. He again performs motor imagery, so he presses his button with the brain, so to say. And then we stimulate 2 other channels, 1 and 2, Y1 and 2, first to close and also to stabilize the wrist here so that he can really grasp the glass. And then when he's done with drinking, he can reopen the hand and we can stop the stimulation. So you see, by converting this rather complex movement into a sequence of binary decisions, we can really restore function. And this was the first time the video you have seen of the patients after his accident that he really could grasp something himself, which is a major achievement. Okay, second point I would like to make is the improve loss functionality application. We already heard a lot about stroke rehabilitation, so I don't need to say too much. But what I want to say is that by recording the EEG here, extracting some of the feature, now it doesn't matter what this is, this MRCP, and then by again using stimulation, so sticking to the same technology, we could close this feedback loop again, which is required for the brain to learn. Because correlation is not enough, because in order for neurons or for this neuroplasticity, we heard about this neuroplasticity, so that the brain reconfigures to some extent structurally, so that areas which can take over this lost functionality, we have to synchronize to some extent the cause and the effect. And of course, by imagining without moving, this is not as efficient, but I could detect the intent to move and then trigger stimulation, and in this way close the feedback loop. And indeed, this is working. There was just my colleague also here at Essex, Simis, they did this, and we started now discussion, or we will hopefully start soon again once the COVID pandemic is more or less under control. Hopefully we can go back to stroke patients and really evaluate the efficiency of this approach. Another of my big visions, let's say this way, is how we can use BCI is to have a kind of Harry Potter sorting hat. Imagine you go and you have a stroke, you go to the hospital, as Damien already mentioned, I guess, or was it a question? One thing is you need immediate communication channels, so kind of an adaptive BCI, which gives, adapts to the user and allows you to say, have yes, no answers within minutes, ideally, is what we need so that we can make decisions. But also would be really interesting to see which brain network are intact, which capabilities of the patients are still intact, so that we can do, so that we can optimize or support medical professional in therapy planning. If we know motor learning is no longer possible, or just to some extent, then maybe we can focus the resources on logotherapy or different approaches. So this is also a huge, tremendous potential, I think, which this BCI technology can have. And of course, in this context, we can use BCIs also as a research tool. Because what we did in this study, this is not data which we, from the video you've seen before doing walking. Here on the left-hand side, again, a figure or image of the brain. What you see on the vertex, this is the area which is related to foot movements, to walking in this case. And what you can see on this curve here, I will soon play the video. So this is the gait cycle. So you see here, the left heel down, here's half of the gait cycle, again, left heel down. So what we were able to do, we were able to use BCI technology to decode gait. So basically we found some of the networks which modulate based on the gait. Speed, so we can now extract from EEG signals speed velocity, for example, to some extent. But what it also helped us is to get a better understanding of how the different brain networks interact and how to interpret them, because this is a very important tool. Okay, now let's go to number 4 application, which is the replace. Sometimes, again, it's no longer possible to restore or to improve the function, so we have to replace it. And what I would like to do with you now is a small experiment. What you will see here is a matrix with different letters, and let's assume we are a patient and we are hungry and we would like to communicate that we want food. Yeah. So what I ask you to do, please, is focus on the letter F when the video now starts. So hope you can see it. So you should see it blinking at some point. Focus on the letter F. And each time you see the letter F, then maybe count how often you see the letter F, and the letter F was detected. Now the O, we focus on the O, and the O appears. So you see, with this is a different way of how we can design brain-computer interfaces. So far, we discussed about oscillations, or induced activity. In this case, we react to an external stimuli, and we call these signals evoked potentials. So basically what we have seen so far, what you see here, again, the cortex, or where the cells are, here some other structures in the brain. And if we start imagining or start thinking, start processes, then what happens, there is some oscillations start here, some network gets active. And of course, if we measure the EEG on the surface, we see this oscillation. In the case of evoked activity, is the information comes from afferent fibers, so basically from sensory stimuli, and it ends up in the cortex. And we basically measure the distance or the shape of the curve, the signal which appears from the occurrence of the stimuli until we consciously process it. Like this is the signal processing chain. So we have different letters. If we now take segments of the A, for example, we align them and then take the average, then what we would see is a curve something like this. So the first 100 milliseconds or more or less is just the information from the sensors in the eye to the visual cortex. Nothing else we can say at the moment. But if we compare this with the letter F, if we want to spell food, for example, then we see that here at later component, because it takes some time for us to perceive it and to process it, the shape changes. And again, now we can train a computer to detect the difference between this shape, and so we can set up a BCI. Let me move forward, because otherwise I'm run out of time. Sorry about that. Another, the most common, or the modern trend now is to enhance functionality. So let's assume we want a detection of stress levels or attention if we drive a car. Camille already mentioned this. So how can we enhance the functions? Now, one project which Federica, a PhD student of mine, is currently working is something called the neuroadaptive technology. Imagine you want to learn mathematics and we have a learning environment, and wouldn't it be ideal if the content, the documentation, the questions could be adapted to the stress level or to the workload of the user? Would be ideal. So we can enhance and optimize learning in this context. Another, this is related to a question which was just asked before, gaming. What we did here is we interfaced a commercial game, so World of Warcraft, with our BCI, because we think, yeah, we don't need to reinvent the games. There are tons of really good games, application in general out there. So we should interface with those. So their usability again comes in. But also imagine now, and this was something which just the Valve scientists were saying just a couple of months ago, if I'm not mistaken, or late last year, that imagine if we use now BCIs to change the gameplay, yeah, to create something really new for you. The game adapts to your feelings, would be really great. And you see here already that the present and future maybe starts to merge, because these are things which we can already do now. If you look at all these publications also before, they are dated back a couple of years already. Okay, but let me continue some other trends. A really good trend at the moment is brain-to-brain interfaces. Imagine we can transmit information from one brain to the other. And one study which a colleague at the University of Washington did is, again, we have here a computer game, a user who sees the game, but he's not playing the game. He's just imagining he would like to press the button, and then what they did, they sent this information over the internet to a second user, which here they use transcranial magnetic stimulation. So basically you apply magnetic fields on the outside of the brain. We know magnetic field from before induces currents, and this magnetic fields impulse induces then currents which activate the motor cortex and lets the user press a button. Hope you can see this here. So here is the player. This is the coil where soon the stimulation will be sent. You can see here. Yeah, okay, you've seen it. That's quite quick. But you have the link below, so you can see the whole video on the internet. Another emerging trend is bidirectional BCIs. This was also something which I guess was already in the question. So just decoding from the brain is difficult. We should also incorporate sensor information. So we not only encode information from the brain, but also we decode information from the brain. And this is what again, Rao proposed, that we have some external sources. We combine this with brain activity. We do some more or less sophisticated machine learning. There was a question about genetic programming or algorithms and deep learning. Yes, all these technologies are used. But then we can also stimulate again the brain so that we can get a better, or make use of the resources of the humans which are still intact, if we want to, for example, improve or restore the grasp. Yeah. So you combine as much information as possible. And the last idea I would like to show you is collaborative BCI, so brain nets. So far we always talked about one brain, but what if we combine the information from different brains together into one, or fuse this information so that we can make some group, or we can do some group decision making. Again, this is a work from Anna here from Essex, where you can have where she had an image search task, and you see here, you see it here, it's highlighted. It's an aeroplane. So by using BCI technology, we can extract information from the brain signal about where approximately an object is, which we are looking for. But also, if we combine the information for 2 or 3 people, the detection accuracy significantly improves, which is quite good. So to summarize, so that I'm not too much over time, the trends I would say for the future is it's all about function improvement and cognitive enhancement. So targeting learning, memory, decision-making, also situation awareness, but also the use of neurostimulation, like this EMS technology we have seen before, or others like electrical stimulation or direct current stimulation. So there are different technology out there which are currently tested and evaluated to see what is the impact on function. If we talk to the challenges, I think we just have to be careful because there's a tremendous hype at the moment on BCI and neurotechnology. So we just have to be responsible on how we deal with this. We definitely need better recording technology from the outside. Again, would be ideal if we can narrow it down to fewer neurons, then we could do some better decoding. There are some efforts in this, like tripolar electrodes or neural dust. What Camille was saying, what's missing is still the intuitive control strategies. We use motor cortex. Historically, let's say it this way, this technology was developed for people who are paralyzed, and of course, since if these motor areas are intact, we can use them for control. But maybe there are more intuitive strategies on how to use a BCI. I think this is the biggest challenge, or one of the bigger challenges we have to face. And of course, last but not least, ethics, privacy, and security, because we don't want to really strange things happen with neurotechnology. Yeah. So we just have to be aware about this. So the take-home message for me would be that BCIs, I hope I was able to show you, they come in different forms and they have tremendous potential, and basically just imagination is the limit. But also, like Peter Parker, so the Spider-Man fans among you, they know who that is that with great power comes great responsibility. So we should really be careful on how we use this technology and make it safe and secure. One last advertisement. In this context, the University of Essex just launched a Bachelor in Engineering in Neural Engineering. So basically, if you're interested in studying this, so this is our lab, members of our lab, this is our robotic TMS machine. So if you're interested in studying this, or you have someone who is interested in this, wants to get a good education in this, come to Essex or join Essex, and we can work together to create something good. Okay, sorry for being too long, as often. Thank you very much. If you have questions, again, here's my email, or visit the Essex BCI webpage. Thank you very much.
Brilliant, thanks. That was really, really interesting. I think one of the most interesting comments you made at the end was that it's the future of BCI, a big part of the future of BCI is actually the combination of many technologies. So collaboration is absolutely key here, isn't it?
Exactly. I think so. It's just trying to decode something from a really noisy signal is not really smart if we have other means to measuring it. So now whether this is a BCI, there's a discussion in the community, because as soon as we combine it with other means, but at the end it's about patients and how we can help people to achieve their goal, especially for patients, and then we should take all information in and make the best out of it.
Yeah, we've got an interesting question here from Tamal. I'll ask Damien and Camille to join us as well, because I'm sure there'll be questions for you here as well. So Kamal asks, is there ways for BCI for malice? Sci-fi options like thought implementation and extraction?
Again, the limitation, imagination is the limit. I mean, it's of course we have to consider both sides now, like with any technology. We can do good, we can do bad. And if we can stimulate to recover muscle functionality, once we figured out how memory works, so there's still many open research questions, but then of course there is a risk that you could stimulate the brain in a specific way or condition the brain in a specific way to change memories. So we have to be aware of this risk. I'm at the moment I'm not as afraid of this risk, because I mean if we really want to manipulate many individuals, let's say it this way, in a malicious way, go to school and educate the kids in a specific way. And that's much more efficient probably and easier than targeting this. But again, so jokes apart, we have to be careful. We just don't have the understanding, but as soon as we know how this works, we probably can do some a lot of good things, but also bad things.
Yeah, and probably the important thing is that we start discussing this early, discussing ethics and everything, so that we're not caught by surprise later when there are problems.
Yeah, I mean, we probably will be surprised because, you know, as you never know how technology and the use evolves. You see this with mobile phones, you know. It started for talking, now, yeah, people don't use it for talking, they use it for all different kinds. So, but anyway, sorry, there's a lot of questions.
Just on the ethics thing there, Charlie, there is a report by the Nuffield Council on Bioethics that was released in 2013 that covers neurotechnology ethics in quite detail, and it's very good. It's worthwhile read for anybody interested.
Yeah, yeah, and I'd also recommend the Royal Society's iHuman report, which was published last year, which also covers the ethics to some degree as well. So do keep typing your questions into the Q&A box. One's just popped up from Ross Hawley. Have any of the panel had experience with using music or music applications?
I mean, I can ask, or I can answer. Yes. So we had a music composer, so in Multiple Lab, we developed a music composer using this evoked potentials. So basically you look at the notes and then you can compose music. But together again, so I did my postdoc in Seattle, so I have many connections there. And with the Swedish hospital in Seattle, we also used BCIs for musicians who had a stroke or were impaired, and allow them to create music. So I think art, I wanted to cover it, but already now it was 5 minutes over. But art is definitely something really important for many patients, or for many people in general, and they want to express their music capabilities, or painting. It's the same, so it's not just music.
Yeah,
maybe
we use. Sorry, go ahead, Camille. Go ahead.
No, I just wanted to say that if people are interested in BCIs for art, maybe they can go to this website of Brain Painting by the team of Andrea Kübler, and they did like amazing things that instead of just improving some vital things like communicating, they also think that it's important for people to express themselves. And for ALS patients, they managed to design on a system that is called Brain Painting, and there was then exposition in the museums. So I think it's really great.
Yeah, thank you, Camille. And we use music in quite a different way for neurofeedback in terms of, I showed you the visual feedback where you're moving a cursor from left to right. Some people that we work with are unable to see, or we don't know if they can see, so we use sounds where we pan the sound from left to right. And we normally start off with a pink noise, which is very easy to localize in space. So sounds like an old broken TV, so it's not very interesting to listen to. So we move then on to a palette of different musical genres that includes rock, reggae, and these are just samples, 4 seconds long, and the person has to imagine movement and push the musical sample to one ear or the other. This can be quite useful when working with patients and sitting with their family in terms of, you know, we talk about the genre that the patient might want to might perform the best with, and get a little bit of dialogue and competition going, and see who can guess which genre of music the patient will do the best with. So that's another way of using music in BCIs.
Yeah, thank you. Just going back to the ethics point, Stuart Nolan has just put a useful comment here saying that IEEE are in the process of developing a neuroethics framework for engineers. So something to know about. Kamalos, again, resolution seems to be one of the biggest issues. Can the panel comment on direct brain implants like the one Elon Musk is working on?
Yeah.
Does one of you want to take that?
Yeah, I tried not to mention those those names. I mean, for direct control, I guess you see this from the trend. It's probably implant is the way to go because of the spatial resolution, unless technology evolves in a way that really can tackle in smaller batches of cortical neurons and interpret what they're doing. But again, we just get this bird eye view. What I typically, so a good example is typically always imagine you are in a helicopter, I don't know, 10,000 feet above the soccer stadium, and you have a microphone and you would like to listen to two people, the conversation of two people. It's basically, this is the challenge we have to face. And this is even oversimplified because we would be even higher. So if we really need the resolution for good control at the cortical level, for me, the only solution is to go in there. So for this application, probably invasive will at some point, if again, ethical issues, infections, I mean, if this is solved, then this is the way to go. But also here, there was a survey some time ago, forgot the name of the research, where they asked patients whether they would use an implant system or a EEG-based system if they have the opportunity. Because we are all healthy, so for this, it sounds science fiction to us. But if you are in heavily disabled and the brain is the only organ which is more or less not affected, and then you open it and put some cable in there figuratively, many would not do this option. So they would go for maybe not as a reliable signal, slower, but at least not having maybe additional issues with this. So I think there's room for both, for really dexterous control of robotic cancer. So I think at this stage we have to go invasive. But again, I mentioned the neurodust, which is a completely different way of measuring neural activity, which is a small particle you put into the brain, and you can kind of fix them, whatever fixing means in a gel structure, and then they really record from this level, and they are able to, via ultrasound, to transmit it on the outside. So there are ways, but again, then we would need to put a lot of technology in there.
Yeah.
So that's my take on this. It has an advantage for specific applications, but yeah, not
I think that it's always the same benefits on risk ratio that should be considered. And if one day we manage to have safe systems that bring more benefits than risk, and if these systems are accepted, then implants could be used and could be useful for many people. But yes, we have to work on this balance, and also implanting the electrodes is not sufficient for BCIs to work. Once again, the other aspects, like as Reini said, the comprehension of the neurophysiological mechanisms is very important, so that we can find intuitive comments that are reliable for the people to control the system. And also there are many aspects of learning, once again, cognitive aspects that are important for people to learn to use the system. So we should not forget that the implant is not the only issue in BCIs.
I'd just like to turn to regulations now. We have a question from Christine from MHRA, who asks, during your research, do you consider that some aspects of BCI and intended use could potentially be classified as a medical device? As there will, of course, be different regulatory aspects that need to be considered if it is indeed a medical device.
I mean, the research not, but there are many applications where we have to go to all the regulatory aspects and comply with the medical regulatory guidelines. So yes, and also because there was another question on whether it was already assessed. If we work with end users, of course, we have to take devices or use devices which are approved, which are medical devices, and the technology so far, if we just use it for research and not for diagnosis or for planning, then it's still research. But of course, if this technology then at one point enters into the clinical operation, then we have to comply with all the rules, and we have to stick and do all the testing, including development.
Yeah, just many assistive technologies are not classified medical devices, but as Reini says, if it's making its way into the clinic, or you're making some decisions based on responses received from the patient, that changes care pathways or diagnosis or has some life-changing decisions, then there's certainly a medical device classification for that type of technology. Our trial currently with the large cohort is considered a basic science study. You know, once we've established efficacy for clinical use for augmenting diagnosis, then we'll be following that up with a medical device study.
Yeah. But so I suppose the advice would be if you think there will be any medical applications to BCIs, get in touch with MHRA.
Yeah, for sure, yeah.
We've just had a question here, if we can share all the references we've been discussing. Shelley, please can you remind me to add that into the email that we sent out? So we will include all of those references. We've got a question here from Sanja, who's a medical student, and this area of research seems to be very fascinating. What's the best way for her to get involved in research in BCIs?
Yeah, well, you know, at undergraduate level, we have, like, we're in a computer and electronics department, so we have undergraduate students doing projects that involve maybe development of an application for BCIs. So that's one route. You know, we're always looking for people to participate in experiments, but also potentially to organize experiments. And if somebody's from a nursing or clinical background, sometimes that can be quite interesting to those to get the experience of hands-on EEG and working with people, maybe able-bodied, healthy individuals in the first instance. So there's lots of opportunities. So, you know, I'm sure Reini and Camille will agree if somebody's interested, you know, in getting involved in EEG studies or talking about how they might get involved, we'd be happy to talk to them and see what's possible. Obviously, you can buy a little cheap neurotechnology headset as well, and get involved in EEG in your home if you're interested, and that can be a good experience as well for a lot of people.
And also, yes, for students here, the research labs working on BCIs are very interdisciplinary. So there are computer science labs, but there are also psychology labs and clinical teams and virtual reality teams. So don't hesitate to contact us, and depending on your specialty, maybe I'm sure we can find somewhere interesting for you.
Yeah, I just can agree. So just send out emails and maybe think about the cool thesis for your final year project or so, where you have a medical supervisor, but maybe you can pick one of us as a computer scientist BCI supervisor, and this is a way how you go into this. So basically, we are open. We are a big community, happy to spread the voice and the knowledge.
Brilliant. So we've got two questions here, which I'm going to combine. One is going back to the Elon Musk devices, asking what's the time frame for that? How far away is that from actually being a reality? And then another one here, which is for sort of non-medical applications. Have you thought about things like environmental control, so turning lights on and off or film music, so walking around your house and having Damien's cap on all the time? So yeah, what's the future in the next 5, 10, 20 years?
I can answer the second one. I leave you the first one. For the home applications, there are research exactly on this topic. Is it domotics as well in English, we say? To control?
Yeah.
Okay, good. Easy then. And using the evoked BCIs that Heini talked about, there is a PhD, who defended his PhD. He's called Hakim Si Mohamed. He works in Rennes, in Brittany, in France. And he has developed an application for controlling lights and TV and kettle, etc., using brain signals that are called SSVEP. So the principle is that each light or the TV, they flash at different frequencies, and by analyzing the signal, you can know at which point the people are focusing their attention, because there will be an increase of the amplitude at the same frequency as the flashes. So this is one application. Of course, it would require once again to have an EEG cap all the time and so on. So it's not for tomorrow, but there have been some proof of concepts saying that it could work.
Thanks, Camille. In terms of the Elon Musk and neural lace, it seems to be fairly impressive the way they can sew a thread or a nano thread into the cortex, and some of the earlier results on the white paper look good. It'll be interesting to see a fully fledged publication coming out from that research. But I've seen recently that Elon Musk is going to make an announcement towards the end of August, another presentation on neural lace and Neuralink. So we'll know more then when he anticipates that. But yet again, it's still a highly invasive technology. So in terms of its application, for able-bodied, healthy individuals, it's probably a long way off. Potentially in the clinic, it's got more applications in the shorter term, but still, given its invasiveness, there's probably a few years left in that. That's my opinion, my assumption, but I may be corrected on that.
Yeah, the question whether we talk about the period of disappointment, no, because of the hype. No, but I guess the question is whether the question was if invasive technology is already ready. And there I would say yes, because there was Nick Ramsey in the Netherlands. He just had a pilot where patients, or ALS patients, really severely disabled patient, had a system implanted, just binary switch, and it's in these patients now since, I don't know, 2 years, 3 years, and still working, and they feel much more confident. So it gives them just this additional safety feeling to be able to at least call help if something really tragic happens. So the technology is already here, I would say, for very simple communication. Of course, now they have to undergo all these medical device regulatory cost issues. But from this point of view, I think we are already very, very advanced now. If this answers the question. Now, whatever now Elon Musk plans to do, we will learn by the end of August or September or next year. But I'm pretty sure they can pull off something really remarkable with the funding at the end they have. If they cannot do it, then either they ask the wrong questions, so they should work with us, or it's maybe there's still limits. Many things on the brain we don't know, many technological issues, biomaterials issues. So there's just many things going on. So in terms of time, I agree with Damien. So that also answer the question, not just like a politician around. Yeah, probably 5 to 10 years is a good period, because we already know now it's working. Creating a product out of this will probably take 4 to 5 years. So it's a reasonable time frame, but not basically the matrix or avatar, but probably one very basic functionality. And also, if you think about BCIs or neurotechnology, I mean, cochlear implants or artificial eyes, they are around since quite some time and working. So this technology, so we already have a sound technological basis for this, not just for these active control applications, I would say. But for Parkinson deep brain stimulation, these technologies, they work quite robustly, at least to my knowledge, and it's more or less the same, very similar principles, let's say, not the same principle.
Yeah. I think, Damien, I think it was your talk, you mentioned that BCI hasn't yet found the killer application that is going to really make it mainstream. Do you see, what do you think that killer application will be?
Yeah, well, I suppose the first thing is, make the headset very easy to use, very easy to put on. It's like putting a cap on in the morning. Then you have to confront the non-stationary challenges. EEG is a very non-stationary signal, so it might work today, not tomorrow. And have the algorithms really adaptive to time of day, type of person, affective state. So if we could solve those things, then killer application. I think gaming is one of the applications that I can see gamers tend to spend a long time focusing on mastering fine motor skills in gaming, and BCIs with Neurogaming offer all the same challenges that games do, challenge, competitiveness. When we get a few students in the lab and they're trying to control their brain activity, they want to be the best at that. The problem is, it's quite a bit slower, a bit more latent, and how can you capture the gamer to really engage with that as opposed to what they're used to in terms of the controller, the manual controller. So I think if that's one area, I think we could really attract people and large user groups and intensive engagement, and that might be really helpful. Beyond that, I think people are interested in all sorts of applications for not movement independent interaction with their environment. So wireless controls, but would you really want to put on a headset to walk around your house switching on and off lights, or unless you have some physical disability that prevents you from doing that normally. Yeah, gaming would be my one. I'm not sure if Rainey and Camille agree with that, but I think from just an intensity of people using it, I think that's got lots of potential. And it mightn't mean that you control the full game from beginning to end with a brain computer interface. There might be little points within the game that do BCI challenges, or there could be passive and active control where you're monitoring brain activity whilst the game is being played normally, and that can influence the game passively, and then you have an active control period where you have to do something with motor imagery or visual evoked potentials. Yeah.
And I also think that neurofeedback training will be very much used in the next few years. For instance, surgeons to improve their precision of movements, pilots to improve their attentional and avoid tunneling, or as athletes to improve their cognitive or motor performance. We've done something with soccer goalkeepers to improve their covert attention abilities, and this is something that could be more and more popular, I think, in addition to video games, because I completely agree with video games.
Yeah, computer games are the low-hanging fruit, because as Damien was saying, they really engage a lot, and they are willing to spend hours of training. We did not talk about training times, but we talk about, if we use current technology, months of training. So you really have to be willing to do this. But I think that there are a tremendous amount of applications once we have the technology at the point where it's really, making this benefit. It just has to be better than not having it, because I think, we all strive to perfection. That's true. But how often happens that maybe you drop a pen? So, we are not perfect. So we just need to have a system which is good enough and supports decision making, supports, enhancement mostly, I think. Whether it's for athletes, for students, so I see many potentials, many potential applications, but like very targeted. So gaming is probably there for the masses, the easy one. And as I try to at least in my talk to highlight Valve, they also on this. So they just last year released, or this year I can't remember, some news, but you can find it on the internet where they had they plan to design games who adapt to your the gameplay adapts to your feelings, emotions. If you are super anxious, then maybe even more zombies come in, or if you're super relaxed, or they put you in a state where you're super relaxed, because then the effect is even better. So I think this is a standard application almost, what will definitely be happening, and people are trying this in several years to do this. It's just difficult to, as Damien was saying, and it's also Camille, to bring it to the market, because if if the technological barrier is away. So if you just have to set it up, it's auto-configuring. Yeah, this is, I mean, one of my research. It was just to plug it. Here, it's this automatic adaptation. Because if we find a 5-minute calibration cycle so that you can use the system, then it's much better than I have half an hour of positioning it, training it, and then after 40 minutes, yeah, it's working. But most people won't have this. So I think applications, there are many. There's many killer applications, but there's some small tunings, tweaks we have to do until we are there. But they're not so far away. So.
Yeah, I'm just conscious of time now, so I think we'll have to draw this to a close. But thank you very, very much indeed to all of you. It's been absolutely fascinating. We will be sending out the presentations after this, and the recording will be available on YouTube. We'll also try and add some of those references into that email as well. There's a final comment from Christine from MHRA, just letting people know that they can get in contact with her. So if you go to devices.regulatory@mhra.gov.uk, do get in contact with them. But yeah, so we'll just wrap this up, and thank you all very much for listening, and thank you guys for your presentations.
Thanks, Charlie.
Yeah.
Thanks, everyone.
Thank you very much.
Thank you very much.
Good.
Bye.
All the best. Bye, folks.